Okay, I'm going. Welcome everyone to the third session of How I Do a Case Of. And we are extremely delighted to have with us today Dr. Arun from Tacoma in the United States and Dr. Ajay Nayak and Dr. Karthik Bhargav, who are going to be the moderators for this session. We are going to be speaking on the biophysics of ablation, specifically tailored towards radio frequency ablation. Given the large number of energy sources that we have coming up these days, it's important to understand what creates a lesion, and it remains the cornerstone of what we do in electrophysiology. So over to you, Dr. Ajay and Dr. Karthikeya, and hope we have great fun in the hour and a half to come. Thank you.
Thank you, Deepak. Thank you for doing this. And Dr. Arun, thank you for being here. Arun is our very own. He's from Hyderabad originally, then trained at Kansas City, Cleveland Clinic, presently at Seattle. And I'm very happy to have Dr. Karthikeya Bhargav here as additional moderator. We'll keep interrupting Arun and asking questions, and everybody is welcome to put in their questions in chat. And at the end of the session, we'll have a good question answer session too. Just a couple of things more. I'm very happy to say that we've got into a MOU with both Heart Rhythm Society and the World Society of Arrhythmias. So, in fact, HRS and IHRS are going to collaborate in these sessions, and all these sessions will be put on Heart Rhythm 365 for free access to everybody around the world. So, all these videos sessions which will be recorded will be available to all around the world. So, it is excellent to do this. I'll ask Dr. Karthikeya to speak briefly, and then Dr. Arun can take over.
Thank you, Ajay. So it's a very nice thing that it will be available to everybody across the globe through the HRS as well as IHRS website. And for today's session, I know it will be a great learning experience for not only fellows, but even for experienced electrophysiologists. And even for me, because though we do RF ablation since long, we still don't know sometimes when to have a better lesion size, what to do in certain difficult situations. So I'm sure it will be a great learning experience for me. And we have with us Dr. Arun Sridhar, who will be talking about this. And as Ajay said, we will be interrupting with questions in between, as well as at the end of the talk, we'll have a good discussion about these things. So Dr. Arun Sridhar, please.
Good morning, everyone. Thank you very much for having me. This is actually a talk that I used to give to my fellows every year. So I know a lot of you are practicing physicians. So if some of this is elementary, please forgive me. I tried to incorporate some stuff that is probably going to be useful for all of us in our practice. So I wanted to start with a few questions, like just to get a baseline of what the understanding is, so that we can discuss more on that particular areas. So let's do a question one. During RF ablation, what temperature does the tissue need to be heated to achieve irreversible injury? 45 Celsius, 50. Temperature is not as important as the delivered wattage in determining irreversible tissue injury.
I'll give it about 30 seconds before we close it and we can take a look at what happens. Please ignore options 4 and 5. Very interesting to see if someone takes up option 4 and 5. Okay, just give me 1 second. Here you go, Arun. These are the results for you.
Okay, so choice 2 and choice 3. Okay, very important actually. So we'll come back to this. So some people say 50 degrees Celsius, and some people say that like we should wattage is the most important thing. So we'll talk about it. This is actually a very important concept. So second question, you're doing a PVI, pulmonary vein isolation. You're ablating the left atrial appendage ridge portion with a 4 millimeter irrigated catheter. Power control mode, 35 watts. Impedance gradually drops to 12 ohms. What do we do? Stop the ablation and do an ice survey for effusion. You might have caused a steam pop. Stop and readjust the catheter. You might have dropped into the pulmonary vein. Continue your ablation and keep coming down the ridge. You're doing well.
Okay, I'm going to end the poll. We have about 34-35% participation. These are the results.
Okay. So there's a split between choice 2 and choice 3. The answer is choice C actually, choice 3. Continue your ablation and keep coming down the ridge. You're doing well. We will talk about this too. Next question. This can be confusing, but at the end of this talk, it should be fairly easy to tell. With constant 30 watt power for 20 seconds lesion, 20 seconds time, which catheter creates a bigger lesion? Everything else is constant. Contact force, electrode size, tissue interface, everything is constant. You have irrigated catheter and non-irrigated catheter. So the amount of energy released is watts multiplied by time. Okay, so like a 30 watts for 20 seconds would be 600 joules. So you are delivering 600 joules. Both catheters are the same. Both catheters are delivering the same amount of joules, but one is irrigated and one is non-irrigated.
I'm just going to wait for a little bit more because we've just had some feedback that the questions are moving around too fast. So I'll just give them some more
Okay.
time to answer. The tips are the same, right, Arun, for both of them?
Yeah, tips are same, 4 millimeter.
Okay. There's a 50% chance that you would be right. So I think everybody should take that chance. There we go. That's the result for this session, this one.
Okay. Yeah, it's actually the wrong answer. So so we can improve this. So like we'll talk about it. So I think like I made my talk into different sections. So we're going to talk about different things. The first thing I'm going to talk about is some history of ablation and like the catheter technologies, because that is very important for us to understand how the field evolved. And then we'll talk about lesion formation and how to monitor a lesion and how to avoid complications. So the most important slide in this entire lecture is going to be this one. So how do we actually create a lesion? So what is the purpose of creating a lesion, a thermal lesion? The whole point is we want to create an irreversible injury, and we want to make the tissue non-conducting. So that is the whole purpose of ablation, right? So like we want to create an injury that is irreversible and it should not improve after we stop the ablation procedure. So this was a fundamental study that was done in 1993 by Dr. Haynes. Dr. Haynes is one of the pioneers of these studies. Like they did a lot of guinea pig muscle preparation and thigh muscle preparations, and they did a lot of fundamental studies on that. So when you heat a tissue to less than 45 degrees Celsius, almost no injury happens. When you heat a tissue to 45 to 50, like there is a good amount of injury, but depolarization can occur if you give a high amplitude electric current. Like if you give a higher millivolt, then you can still depolarize, meaning that the tissue injury is not reversible. But once you reach 50 degrees Celsius, the tissue is irreversibly injured. Okay, so like it's durably injured. So you ablate and like come back half hour later or 1 day later, the tissue is still non-reversibly injured. So whenever we are ablating, the target tissue temperature that we want to create is about 50 to 55 degrees Celsius. You can go up to like 55 degrees Celsius to be safe, but you should, if you achieve a tissue temperature of less than 50, there is a chance that you can create a lesion and you think that it is good, but it can come back in a couple of days. So this is the basic fundamental concept. Like you have to create a thermal lesion, and whatever we do, however we do, we are trying to achieve this tissue temperature. So this is again a slide from the same paper actually. So normal excitability, and this is like 45 degree temperature, and at 50 there is reversible loss of excitability, and beyond 50 to 55 you have irreversible loss of excitability. Okay. So pathophysiology of a hyperthermic lesion. When we heat a tissue, how does the injury happen? There are multiple mechanisms. The most important concept is the thermal poration of the cell membrane. So we are creating pores inside the sarcolemmal membrane. which releases the ions, and the ion channels are disrupted, and there is like a loss of differential conductivity in the membrane, and that leads to cell injury. The second important issue is microvascular injury. So like you also create an issue with the create microvascular injury where the small blood vessels are injured, and this is what leads to lesion maturation. Like sometimes when we actually burn a VT or when we burn a papillary muscle PVC, it feels like we haven't completely gotten rid of it, but a few days later the PVCs disappear. That is because of lesion maturation, and that's because of microvascular injury surrounding that tissue, which leads to ischemia eventually, and then because of ischemic injury the tissue dies, and then you can have a durable lesion. So about at 45 degrees Celsius, non-specific ion transit across the cell membrane results in cell depolarization. Greater than 50 degrees Celsius, there is a calcium overload inside the system, inside the cell, and that leads to irreversible tissue injury. So bottom line is we need to go to about 55 degrees Celsius to achieve a irreversible tissue injury. So how do we achieve a tissue temperature of greater than 50? And we will look through the history and see how we achieved this. So the first ablation that was done was in 1980s. It was actually in 1982. It was done by Mel Scheinman in UCSF. So they used direct current ablation. So this was used for AV node ablations for refractory AFib. They used it on 1, 2, 3, 4, 5, 6, 7. There were like 7 patients that they did. Sorry, 5 patients with recurrent AFib. One of them actually died. So so it was a very pioneering work. Like they used DC current and directly produced a shock in the tissue, and that led to tissue damage. So the principle in this is different compared to hyperthermic lesion that we use right now. So what happens in a DC current ablation is that you give a very high voltage pulse for a very short duration, about 2 to 4 milliseconds. This creates a shock-like effect, like the cell membrane destruction and mechanical tissue disruption happens because of barotrauma. So there is a pressure release in that area. It's like a shock. There's a shock wave, and then there is a small explosion, and that leads to cell damage directly because of barotrauma. And the second mechanism is you can have an explosive electroporation where the cell membranes are completely destroyed with the shock wave. So this is not a thermal injury. So this is actually a shock wave kind of this is a direct trauma to the tissue. And you will see that similar concepts are applied in the most modern technologies, like in PFA, you have electroporation, but that is a more controlled electroporation. And if we have time, we'll talk very little about it. Most of the focus is going to be on RF. So direct current ablation, why did it go out of favor? There were multiple problems. First one was barotrauma. It led to like a significant injury in the surrounding tissues. Pressure wave and shock wave cannot be controlled that easily, and pain was significant enough that requiring general anesthesia. And the lesions were difficult to control. So sometimes it led to arcing and spark and explosion and things like that. And then like the other issue was a T-wave shock. Like if you deliver the shock in a vulnerable period of the myocardium, you can end up causing VF. So we exploit this phenomena when we are checking for DFTs for ICDs, right? Like we deliver a T-wave shock and put the patient in VF. So that can happen with a DC shock. So the question is, can we apply lower energy in a more focused fashion and create injury? So that's the idea of RF ablation. So this is a brief timeline of how things evolved. So in early 1980s, you had DC ablation era, quickly fell out of favor, and late 1980s, people were doing experimental studies in RF ablation. 1992, 1993, these were the fundamental, guinea pig preparations and all that stuff. All the lab work, in vitro work was done around 1990s. By 2000, by late 1990s, RF ablation was already popular and people were experimenting with it in different tissues. And 2000s, cryoablation came up, and 2020 PFA came up. However, RF still remains the king. Like it is still the most important tool that we have in our arsenal for any kind of ablation. So RF is like still widely adopted, and like because of the ability to control the lesions really well, and people being able to understand the physics much better than some of the other things that we talked about. So again, going back to this slide because this is very important. So irreversible loss of excitability happens around 50 to 55 degrees Celsius. Okay, so one important concept I wanted to just talk about was where does this RF frequency fall? If you look at the wavelengths of electromagnetic spectrum, RF is actually one of the largest wavelengths. It's like very low frequency compared to everything else on the electromagnetic magnetic spectrum actually. So you have like cosmic rays and gamma rays on the far side of the spectrum, then X-rays, ultraviolet, and lasers and all come around this area, like ultraviolet, visible, and infrared lasers. And then you have microwaves, and then you have radio waves, and we fall somewhere around here. So medical RF is an AC current, but the frequency is around radio frequency. So frequency is 500 kilohertz, wavelength is 600 meters, and compared to pulses of DC, it causes very little collateral damage. So why do we use RF, and why don't we use any of the other spectrum mentioned here? Because a lot of these things can heat tissue, but we still use RF because it's a sweet spot. So its RF is very controllable, and it also has optimal depth penetration. When you look at microwave actually penetrates much deeper, and but the control is very difficult. So like it leads to larger lesions. The predictability of the lesions is not that good, and like even if you have good grounding, like you can't predict where the waves propagate. So we use it in larger targets like tumors, etc., but it's difficult to use it in cardiac tissue. Laser is super precise, but it produces very superficial lesions, and laser lesions are also thermal lesions. So these are used in optical procedures and like ENT and ophthalmology procedures, but we don't use it in cardiac RF. So then I go on to non-irrigated RF ablation catheter, which is one of the first catheters that was invented.
Can I
we have a
interrupt?
question? Yes, of course, yeah.
Yeah, so now we have understood that for a good lesion, we need to have a tissue temperature of 50 degrees. That's very important.
Right.
But for the fellows and those who are beginning to do this electrophysiology and ablations, I would like to just clarify that what you see on your ablator screen, that temperature is actually the catheter tip temperature. It can be way different from the tissue temperature that we just talked about. And so, are there any good ways or any ways actually to know the tissue temperature? And if not, how do we say whether you have actually created a good lesion? Maybe you will be covering it later in the
Yeah.
talks, then you can just say that. But just to clarify that what temperature that we see on the ablator screen is not the tissue temperature which we just talked about.
Yes, Dr. Bhargav is absolutely right. So I will talk both about RF and like irrigated and non-irrigated catheters. So temperature monitoring is actually not that easy. Like we don't know what the tissue temperature is, but we have some surrogates to measure what the tissue temperature is, and we use that to titrate our lesions. Okay, so like I will go to lesion monitoring. Like we'll talk about it. There are some ways to predict what the tissue temperature is going to be, but the absolute way to know what a tissue temperature would be is to do a thermal camera. You need to actually use a thermal camera to see like what the tissue temperature and the depth is. And it can only be done in experimental situations. You have to have a direct field of view to use thermal camera. You can't use it inside the human body. So we have some limitations. There are some newer ways where they use some ultrasound technologies to monitor tissue temperature, but those are all experimental. So, but I will, Dr. Bhargav, I will cover lesion monitoring like subsequently actually. So like there are a few ways where how we monitor the lesions, and I'll talk about that. So let's talk about non-irrigated RF. Any other questions actually up to this point? Okay, so I'll go with that, and I'll keep going ahead. So non-irrigated RF ablation catheter. So it's very important to understand non-irrigated catheters because it is the fundamental catheter, and it's very easy to understand. And so this forms the basis of understanding everything else. So when you use an RF, when you use a non-irrigated ablation catheter, all we are trying to do is we are trying to deliver current through the catheter tip into the tissue, and you are trying to target that into a particular area. So initially, what happens is when you put the catheter at the tip of the myocardium and you deliver the current, you create an AC oscillation, like you have like alternating current at a frequency of radio frequency that we talked about, 500 kilohertz, and that leads to tissue ion oscillation. Like inside the tissue, there is ionic oscillation in the tissue, and that leads to heating. So the initial heating that we see is the resistive heating that happens because of all the ionic oscillations. You create a havoc inside the tissues, and that leads to resistive heating. And once that resistive heating zone is completed, like then the heat actually conducts through the rest of the tissue, and then you have something called conductive heating. So this conductive heating, when we say conductive heating, it's a simple thing. Like, you know, what we're trying to say is like it is not in contact with the catheter itself, but it is getting heated because of the heat that is generated in the adjacent tissue. That's basically what it means. So ultimately, when you use a non-irrigated catheter and you are putting it on the tissue, the maximum temperature is going to be right next to the catheter, and then any tissue that is beyond that is going to be cooler and cooler because of conductive heating. Okay, so it gets a little bit more complicated in vivo when you have like blood flow. We will talk about that, but simplistically understand that like if you don't have blood flow, the highest temperature is going to be right at the catheter tip, and then any tissue beyond that is going to be less hot compared to the catheter tip interface. So the amount of resistive heating is like inversely proportional by the fourth power of radius actually. So it's very exponentially decreases the amount of heat. So these are some of the fundamental studies again. So if you look at the temperature of the tissue, this is at 0 millimeters from the catheter tip, and this is as the distance increases. So the maximum temperature is at the catheter tip, and the temperature immediately falls as you go deeper. So bottom line, if you look at this, like you look at the yellow curve, if you heat the tissue catheter tip tissue interface to 80, you will see that you up to 2.5 millimeters you have a tissue temperature of more than 50, but beyond 2.5 millimeters your tissue temperature goes down. So that means you have a good lesion up to 2.5 millimeters. If you take the 50 degree interface temperature, you will see that the like ablation is effective only for like about 0.1 or 0.5 millimeters. So this is the most important concept. Like, so you have to see how much of the tissue you are able to heat to beyond 50 degrees Celsius. As we go deeper from the catheter to the tissue, there is an exponential loss of temperature. Okay, so effect of electrode. So this is again the same thing. So the lesion depth. So as you increase the tissue the catheter tip tissue interface temperature, the lesion depth keeps increasing. So if you heat the tissue interface to 90, your lesion depth is almost 6 millimeters. But if you heat the interface temperature to 60, your lesion is less than 2 millimeters depth.
Dr. Arun, if I may interrupt.
Yeah.
So the next question which will naturally arise in the mind is the catheter tip temperature which is displayed on the system, does that have a linear correlation with the tissue temperature, which is what we are looking at here, 80 degrees, 70 degrees?
Yes. So on a non-irrigated catheter.
Yeah,
yes.
Non-irrigated.
So on a non-irrigated catheter, the electrode temperature electrode is right here in the tip. So when it displays a temperature, so it is actually equivalent to what the tissue interface temperature. The problem with circulating systems, like when we have a blood pool, is that there is actually some cooling effect in the interface, but still, like since there is no direct irrigation on that area, so you can still assume that the interface temperature is what is displayed on the RF generator actually for a non-irrigated catheter.
So that can be used as a surrogate of whether you are delivering effective energy or not.
So the reason it's a bit more complicated is because you have cooling from the blood pool. So when you have a blood pool cooling, you're already having some amount of an irrigated effect, right? So like you're cooling the interface temperature. So the lesion is actually deeper with a non-irrigated catheter than you would expect for that particular temperature. So the temperature at the interface might only be 60 or 70, but you would have delivered more energy than that, and that energy would have passed much deeper.
So by energy, you mean again, are you talking about the temperature below the tip tissue, or you're
Right.
talking about voltage? What are you talking about?
So I'm talking about joules. So I'm talking about the joules. So joules would be wattage multiplied by seconds. So that is the total amount of energy that is dissipated by the catheter tip.
Sure. Okay.
It
Okay.
also brings to the point that you definitely need to be in contact. Otherwise, your
Yes.
cooling is going to be entirely different. So contact remains one of all this is under conditions of contact maintenance.
Contact.
Without that,
Yes.
you probably don't get to make these interpretations.
Right. Even with that, it's pretty complicated. But like, yeah. So like, you have to have contact. So let's look at current propagation and energy dissipation. So this is what Dr. Nayak was alluding to. So when we actually deliver current at the catheter tip, what we are trying to do is we are trying to deliver energy into the tissue, right? So like that energy is nothing but wattage into time. So power multiplied by time is energy. So and that energy is traveling through the body and reaching the grounding patch, and then like it's going away. So where is the tissue temperature the highest? So the highest temperature would be at the place where you have the most focus, the beam is most focused, number one, and number two, where the impedance is actually high. So if you look at the impedance graph, so the impedance is very high at the tissue catheter interface, and then after that the impedance decreases, and then like at the grounding patch you do have some impedance, but because there is a change in material between the body and the grounding patch, but the grounding patch is much bigger compared to the catheter tip. So there is a lot of focused energy in the catheter tip. There is not a lot of focused energy on the grounding patch. So the grounding patch has to be much bigger, right? Like it's always much bigger. So the reason impedance is important, we all say like impedance is our like enemy, right? Like we want to reduce the impedance when we are delivering joules, but it is also very important because impedance is what leads to power dissipation. So when you deliver when you deliver a current to a particular area, if there is more impedance, and that leads to more ionic agitation, and that leads to more resistance, and more the impedance, it leads to more power dissipation. So the current density is low, but the power dissipation is higher in the highest impedance areas. So with a non-irrigated catheter, so we talked about two zones, resistive zone and a conductive zone. And if you look at the lesion depth, the irreversible lesion depth would be that depth which leads to a 50 watt and 50 degrees Celsius and above. So there is always a border zone which was heated up to like 40 or 30 degrees Celsius, and it leads to reversible injury, and it comes back after you stop ablation. How much heat is too much? So the question is like, can we just heat the tissue interface to as maximum as possible so that you can deliver the lesion as deep as possible, right? So problem is we can't go up beyond 100 degrees Celsius. So if you increase the catheter tip temperature above 100 degrees Celsius, you create coagulum formation on the electrode and the tissue, like, and you lead to also char. So char is like basically like a like burning of the tissue, and like you can have char formation. Coagulum is basically like elements of blood and all that stuff. Like it forms a coagulate around the catheter tissue, and that leads to problems. And the other obvious problem is like greater than 100 degrees Celsius can lead to steam explosion right at the tip interface. And if you have a steam explosion right there, it's safer than having it like on the epicardial side, but still like it can lead to bigger problems. So how do you control the maximum temperature at the tissue interface? So bottom line is we need to control the maximum temperature at the tissue interface and still be able to deliver the joules inside of the tissue, right? So that's the bottom line. So that's how you have temperature. That's how you end up with an irrigated catheter. But before we go to that, so what we do in a non-irrigated catheter is we do temperature controlled ablation. So the way we design the generator is anytime the temperature hits a particular temperature, it comes off automatically. So for non-irrigated catheters, the fundamental approach we do it is by using a temperature control ablation procedure. So we specify the wattage, we say like 30 watts or 40 watts or whatever, but we have a maximum temperature, and as soon as the temperature hits that target, the wattage is going to come down automatically to reduce the tissue temperature. So problems with temperature control ablation is that you dictate the temperature of the catheter tissue interface, but you have no idea what the myocardial temperature is. So wattage drops as soon as the interface temperature reaches target. So, and we have to assume that like it is unsafe, and we reduce the wattage and try to deliver it a little bit deeper. So let me ask a question here. So this concludes the presentation on the non-irrigated catheter. So you're using a non-irrigated catheter with a temperature control set at a maximum temperature of 50. Ablation lesion which went much longer than you intended. Like you can blame it on the pedal or fellow or whatever, but like you did not want to burn it for such a long time, but the ablation lesion went much longer. What is your risk of steam pop? Temperature control mode, max temperature was set at 50.
As the poll is going on, Arun, I just wanted to have clarity on
Yes.
one point. All this RF is essentially death by thermal injury, right? I mean, we are talking about joules, we're talking about watts, we're talking about the energy that's going in, but ultimately there is tissue denaturation and death because of the heat that you're producing at the tissue catheter interface, and that's what causes tissue damage. So it's thermal, it's heat, and that's for producing heat, you need the contact that you talked about.
Yeah. So to produce the heat and to produce the heat in the depth, that is the whole point of the ablation. So we are trying to deliver a good amount of heat. Choice 1 wins, 47%. That is correct actually. 0. So when you have a non-irrigated temperature controlled ablation catheter set at a maximum temperature of 50, you can assume that at the tip it's going to be 50, and everything else downstream from the tip is going to be lower than 50, right? So the maximum temperature is going to be at 50, and every time it hits 50, the wattage is going to come down to 3 or 4. So like your wattage might be set at like 30 or 40, but it will never reach that wattage because you're constantly hitting the 50 degrees Celsius. So then what do? Then so I use non-irrigated ablation catheters all the time for AV and RT ablation. So that is my basic catheter for AV and RT ablations. So I set my maximum temperature at 50 and my maximum wattage at 40. And if I see that I'm hitting the temperature too often, like a higher temperature too often, I just drop my wattage, and I want to deliver it more slowly, allow the blood pool to cool the tissue interface, and then that allows me to deliver more joules inside the tissue. Does that make sense? Is that clear? Okay. So if you're hitting that max temperature very frequently with a non-irrigated catheter, you need to drop the wattage so that you can deliver the joules slower and allow the blood pool to heat the tissue, cool the tissue while we are delivering the joules deeper. Okay.
Yeah, one question, Arun, if I may.
Yeah.
This is I agree here. See, especially when you're ablating posteroceptal pathways which have pouches, the impedance, the electrode tissue contact may not be good. As you drop down into the pouch, the impedance drops. So you want to ablate at optimal impedance. So you did mention that you need to have a good impedance. What values of impedance do you think are good to begin, and what values of impedance you should not be, attempting ablation at all?
Yeah, it's a very, very interesting question actually. So it becomes important in two different scenarios. Like Highgrave correctly mentioned, like when you are ablating in a pouch, the impedance can be high. When you're ablating in coronary sinus, the impedance can be high. So you want to have an impedance of around 100 to 110, or like around 120. Anything beyond that leads to ineffective delivery of joules inside the system. So it becomes too much of a high impedance. I don't know if it is actually harmful or not, but I've never tried to ablate in a scenario where my impedance is greater than 150. I've never experimented it, but we have some ways to decrease impedance. So like in coronary sinus, when we are ablating, the reason you have like higher impedance is because like the tissue is all around the catheter tip, and it's all surrounding it, and it's touching too much. So we do something called pre-irrigation. We irrigate for 5 seconds before we even come on the ablation, and that reduces the impedance, because then you have a little bit more space for the catheter, and that reduces the impedance, and then you can ablate it. So even then, like you have to use like lower wattage, because sometimes if you ablate with a higher wattage, the impedance goes up very quickly. So what is a very low impedance? So you can have very low impedance scenarios too, like impedance is like less than 90, and so like there are some patients where they're very thin, and thinner patients, like in some scenarios the impedance is very low. In those people, I actually take off the like a second back patch. Sometimes we have second back patch to reduce the impedance, and we take off the second back patch. The other strategy, high grade, would be to like add a second patch. If you don't have a second patch, if your impedance is very high, to reduce the impedance you can add a second grounding patch, and that reduces the impedance. One of the other strategies that's been described in some papers is like like usually we put the grounding patch in the leg, right? Like I don't know how you do it in the lab, but in my lab it's usually on the leg, because we have so many things on the chest. We have electrodes, we have a mapping catheter, mapping patches and all that stuff. So usually the grounding patch is on the leg, but if you actually get it closer to the chest, that reduces the impedance, because the amount of tissue the current has to travel to get out is actually lower. So like there are some papers where they have shown that when ablating in the terminal CS or AIV, they would actually put a grounding patch on the chest. So that reduces the overall impedance in the system, and then you can burn actually.
Great. Thank you so much.
So, Dr. Arun, just carrying on with the same question, we do a lot of pediatric ablations also. Ground patch is generally standard size, whether you use in adults or pediatric. So often in the pediatric age group, we have lower impedance to begin with.
Yeah.
What is the function of the large ground patch size relative to the body surface area? Is that the reason? And what is safe then in the pediatric age group?
Unfortunately, I don't do a lot of pediatric ablations, but I have thinner patients where the impedance can be very, very low. I probably in pediatric patients, the impedance is even lower actually. I don't know what ranges of impedance you're dealing with. Our standard in our hospital is 2 grounding patches, and typically when we have impedance being low, we take out one of the grounding patches, and that increases the impedance. I don't know if it's still very low with one grounding patch. I think we can go for a smaller grounding patch, and that will increase the impedance. But I'm not entirely sure if that's being done in pediatric age groups.
But we've never had a problem with the ablation. Even though the impedance typical range we get is in the 80s.
80s, okay.
Yeah. And during ablation, there is no issue, even though the grounding patch size will be a relatively larger compared to the body surface area when we compare it to adults.
Got
So
it,
does
okay.
it really have so much of an impact? That is what I'm asking.
So clinically, clinically, I have to go by what you're saying. So like probably don't have a lot of impact. So in theory, if you just speaking theoretically about what happens when you have a low impedance system, your ablation becomes inefficient. You have to deliver more power to achieve the same lesion actually, because the current is going and coming out of the system with a little dissipation of the power. So like when your impedance is low, the amount of power that is dissipated in the system is low. So that's what is happening, but we don't really care about how many joules we are losing, right? So I think that is okay. Like safety of the system, I have to go by what you're saying. Like probably it is okay like with that impedance.
Sure.
Okay, so let's do this question actually. So like an RF lesion is created in power control mode, delivering 30 watts for 30 seconds on a 4 millimeter and an 8 millimeter catheter. Maximum temperature is set to 60 degrees and is not reached by either catheter. Blood flow is the same. Okay, so what I'm implying is that we are delivering the same amount of joules, 30 watts for 30 seconds, that is about 600 joules in each the 4 millimeter catheter and the 8 millimeter catheter. Lesion size will be larger for 4 millimeter catheter, 8 millimeter catheter, no difference. It depends on the baseline impedance.
I do hope this question changes the purchase of catheters. Okay, I'm just closing this one here.
Okay.
And here are your results, Arun.
Okay, so the answer is actually 4 millimeter catheter. The reason for that is like 8 millimeter catheter has a lot of advantages. We'll talk about that. The problem with an 8 millimeter catheter is that there is a lot more cooling forces on the 8 millimeter catheter compared to a 4 millimeter catheter. So when you have more cooling forces, the energy is actually dissipated into the cooling forces, and like overall energy that is delivered to the tissue is actually lower. So the lesion is larger on a 4 millimeter catheter, but the lesion depth might be higher in a 8 millimeter catheter. But if you're just delivering exact amount of joules to both, the larger lesion would be with a 4 millimeter catheter. So that's why that is a segue to cooling. So let's talk about cooling. What happens when you cool the catheter tissue interface when you're ablating? Cool the tissue while you're heating. I don't know why there is this this thing here like marks. I don't know how
That's not you. I think somebody's been able to do it. I'm not able to take it out.
Oh, okay. So natural cooling forces, the blood pool temperature is 37 degrees. So, and we are trying to heat the tissue to like greater than 50. So that creates a constant cooling effect from the blood pool, and it cools the catheter tissue interface. So the way it happens is like, with the catheter, you are trying to create resistive heating and conductive heating, but because of the blood flow, you have like a convective cooling and blood perfusion leading to cooling directly. So when you're cooling greater the surface area of the catheter tip, greater the cooling effect. So with an 8 millimeter catheter, the amount of cooling that you're providing is much larger compared to a 4 millimeter. So in essence, you're actually creating a much cooler surface tissue catheter interface with an 8 millimeter catheter compared to a 4 millimeter catheter. So with an 8 millimeter catheter, this allows you to deliver more wattage without superheating the tissue interface. So that by delivering more wattage in by keeping the tissue tip the tissue interface temperature low, and by delivering more wattage deeper into the system, you are able to create a bigger lesion in the 8 millimeter catheter. So the larger electrodes basically allow you to deliver higher power without excessive current density at the electrode tissue interface. So that way you create a bigger lesion by delivering more wattage. But if you deliver exactly the same wattage, you are not actually creating a bigger lesion. So this is another question.
Arun, I think let's clarify this more actually for the benefit of fellows, especially because most of the beginners actually believe that if you use an 8 millimeter catheter, you will get a larger lesion. So let's see this, what happens is. So now, one thing is important to understand that what we program our wattage in the ablation system as is not the one which is making the effect. What is actually delivered is what is important. So suppose it's a temperature control mode, we have programmed it to 40 watts and 50-degree temperature. And with just delivery of 20 watts, the temperature at the catheter tip reaches 50, so that the system will never deliver power more than 20 watts. And that's what actually matters. What you had programmed as 40 watts is immaterial, but the delivered power is 20 watts. That's more important. Now, suppose you use, and the reason why it is not going to 40 watts is your catheter tip temperature is reaching 50 watts, that you had put the limit to the catheter, to the ablation system initially. Now, the problem with these catheters is that your catheter tip temperature may reach the target temperature very early, and so you're not able to deliver that amount of power that you intend to deliver. And that's why we use an 8 millimeter tip catheter, wherein the cooling by the bloodstream results in a larger delivery of power for the same target temperature. And that's why we are able to achieve a larger lesion. So this is very important to understand, that the delivered power is much more in an 8 millimeter catheter, and that's why you have a larger lesion. But if you had the same delivered power for a 4 millimeter tip catheter versus an 8 millimeter catheter, your lesion will be larger in the 4 millimeter tip catheter, because your current density is much more in the 4 millimeter tip catheter. I hope I am correct, and
You are absolutely right. Thank you for clarifying. You're absolutely right. So ultimately, we need to deliver wattage, and ultimately, we need to deliver the energy deeper into the tissue while keeping the surface very cool. That is the whole point. So if you're keeping the surface cool, but you're not delivering more wattage by taking advantage of the surface being cool, then you're not giving any benefit to the tissue. So I hope this question is a bit more. This is a bit more confusing, but like maybe this will clarify that point. An RF lesion is created in a temperature control mode, delivering 50 watts at 50 degrees Celsius for 30 seconds to a 4 millimeter and an 8 millimeter tip catheter. Maximum temperature is reached a few times in both catheters. Blood flow is the same. So like Dr. Bhargava was just mentioning, so when you set a temperature at 50, sometimes the maximum temperature is reached. As soon as the maximum temperature is reached, the catheter, the RF generator will stop delivering the wattage, so that wattage will go down. So the maximum temperature is reached a few times in both the catheters. Blood flow is the same. Lesion size will be higher in 8 millimeter or 4 millimeter catheter. This is a temperature control mode.
Nice dissection, Dr. Karthikeya. That was really nice. Kind of dissects into what is delivered versus what is programmed, and definitely the current density at the tip.
Right.
yeah, and I'll request everybody to please put their questions in the chat, so that, because I know this is a very confusing topic, but it is of interest to each one of us. So let's put your questions. It may appear to be very silly, but it may be actually very important for every one of us.
Yes, please.
I'm ending the poll here, and these are the results. I think this is the reason why I said that distinction made was very nice.
Yeah,
Arun, over to you.
I think we got it. So like larger using the 8 millimeter catheter, because if you have an 8 millimeter catheter and a 4 millimeter catheter, and you have a maximum temperature set up, you're more likely to reach the maximum temperature with a 4 millimeter catheter, because the current density is higher in a 4 millimeter catheter, and like the cooling effect is lower, so you reach the maximum temperature more often in a 4 millimeter catheter, and that leads to wattage being decreased. But on the other hand, with an 8 millimeter catheter, you have the advantage of delivering more wattage, and that leads to a larger deep lesion.
So, Dr. Arun, let me ask you a couple of more questions. In the past, not available now, but for flutter isthmus region, there used to be dumbbell-shaped catheter tips for 4 millimeter and 8 millimeter also. And the the shape was like this, and you could actually go through the ridges and all, and you could deliver around the ridges better. This was before the irrigated catheters came in vogue. So, what would be the principle behind it? These used to be 8 millimeter and 4 millimeter dumbbell shaped catheters.
Wow, I did not know that. Like I've not seen that.
I would imagine it was for contact, Dr. Ajay, and correct me.
More for the contact, you're at the ridges in the isthmus area, so you're trying to get to the anterior aspect of the ridge while dragging it back, and you could actually get into the dips and all a little better.
It's almost like the speed breakers in India, where you kind of have the elevation and the dump. So your P-body would sit, the tip of the P-body where the waist is, that would go into the depth, and the bulge would sit on the tip. And so you could actually maintain your contact across, thereby delivering that lesion. Now, I think ice has made it much more easier, but yeah, I would imagine that would have been the case.
So what about 2 millimeter tip ablation catheters?
So 2 millimeter. So if you're going from 4 millimeter to 2 millimeter, you run into the problem of having very small electrode interface. The current density is much more high. There is a risk of superheating the interface and giving very superficial lesions.
And these are typically again, I'm asking a pediatric level question. 2 millimeter tip ablation catheters are more used in the pediatric age group. And if you are creating more tissue lesions, isn't that a little more dangerous? Dr. Karthikeya, what do you think?
So first, there is another problem with the 8 millimeter catheter is larger your catheter tip is, lesser is your resolution. So mapping becomes a problem. We use the same catheter for mapping and ablation. So larger your catheter tip is, lesser is your resolution. So other way would be thinking of why not use a 2 millimeter tip catheter, which will have the best resolution. But as Dr. Arun said, if you have a smaller catheter tip, your current density will be higher and your temperature will reach very quickly, and there's an increased risk of jar formation, and so you will not be able to deliver enough power. So 4 millimeter actually was found to be the best balance between your the resolution as well as your delivery of energy. And advantage of using 8, as we earlier discussed, is to have better cooling because of a larger surface area, but there will always be a issue with resolution. If you need to map it very precisely, 8 millimeter is never a good idea to have. There's another question in the chat, which will produce a larger lesion, non-irrigated 7 French versus 6 French catheter, both being 4 millimeter. So as we understand, if the catheter tip size is the same, the catheter French size is actually the thickness of the shaft of the catheter, so it doesn't make any difference. So I believe that the lesion size will be the same.
Same, yeah. So there was another, I just was trying to draw catheter and the tissue interface. If you lay the 8 millimeter electrode tip is actually horizontal, right? So like when you have a catheter which is either vertically placed or a horizontally placed catheter, so like the benefit of the 8 millimeter catheter is only there when you use it horizontally, like when the entire 8 millimeter is touching the tissue. If you're actually putting it vertically down, then power is actually like very focused in this location, so you will quickly reach temperature maximum here and it will cut off. So yeah, like to have the benefit of the cooling forces and like like the power should be distributed, so like you need to lay it flat. So that goes to the other point about like the 2 millimeter catheter. So for 2 millimeter catheter you might reach the temperature quickly, and it might create a superficial lesion. When you create a superficial lesion, the risk of deeper injury is low, but the risk of char formation and coagulum formation is high.
Before we go on to the next part, can you just look at the chat again? There is a question about this very topic.
Yeah, before we go to that question, again, another point is that 8 millimeter catheter, as we just discussed, has a higher risk of char formation, despite maybe allowing more power to be delivered. So that's the reason why it's, I think, nowhere now we use it on the left side of the heart. The best place we use is for typical right atrial flutters for cavotricuspid isthmus ablation, where orientation of the catheter, as Arun pointed out, can actually result in lesser number of lesions delivered with an 8 millimeter tip catheter to achieve a complete line of block compared to a 4 millimeter tip catheter. So we have one more question in the chat, that is, if 20 watts takes the temperature to 50, why don't we consider it as job done, as it is actually the temperature that's doing the job, and tip temperature is the only surrogate we have?
Right. So this is So the temperature that we are measuring is at the interface between the catheter tip and the tissue. So if the the interface temperature is 50, you know that like as soon as you enter like 1 millimeter, the temperature is falling down to like about 30 or 20. Like if you go back to the original graph that we had. So what happens if your tissue temperature is, I'm like trying to, yeah, so if your tissue temperature is 50, within a span of 0.5 millimeters, you're already dropping down to like 35 or 40. So you know that your lesion size is very, very shallow. That's basically what it means. If you give a 20 watt lesion and like the tissue temperature goes to tip temperature goes to 50, that means that with very little energy you have increased the interface temperature to 50. That means not a lot of energy has gone inside the tissue, so your lesion depth is very, very shallow.
Another important point is that it is not the temperature which is doing the job. It is the lesion depth is actually mostly directly proportional to the delivered wattage. Now, the idea of temperature is that you have to reach a tissue temperature, not the catheter tip temperature, but the tissue temperature of 50 degrees to make a lesion. As long as it is above 50 degree, more delivering of more wattage is not going to help you. It may actually be harmful, because if your tissue temperature goes much higher, it will result in steam formation and steam pops. So your idea is to reach the tissue temperature of 50 degrees, and larger the wattage delivered will result in a larger size of the lesion. So it is not the the catheter tip temperature that is doing the job, but the amount of wattage delivered that is producing your size of the lesion.
Right. So 1990s era of irrigated catheter starts. So interface cooling allows for larger power delivery. Exactly what we were talking about. We want to protect the surface and deliver the power into the deeper tissues without superheating the surface. So and like we talked about natural cooling forces, right? Like natural cooling forces are the blood pool and the convection of the blood and all that stuff. So like now we create artificial cooling sources from within the catheter. So, and we try to see if we can cool the temperature tip of the catheter. There were two different types of irrigated systems that were created. One is closed loop irrigation system, where there is actually a coolant that goes through the catheter and comes back to the generator. And this is called as a closed loop irrigation system. And then there is open irrigation system, where you have saline or half normal saline or whatever be the case, like you have a coolant that is coming out of the catheter and it is cooling the tip interface. Closed loop catheters quickly fell out of favor, but then but the irrigated catheters, they are the most used right now. So when you have a 4 millimeter conventional catheter, this is the 4 millimeter conventional catheter, and like you're trying to ablate, you can see that the maximum temperature is very close to the tip of the catheter, and as you go down into the deeper tissues, the temperature falls very quickly. Same thing happens with the 8 millimeter catheter. But when you start cooling that with an irrigated catheter, you will see that the interface temperature is maintained to be low, but the energy keeps going inside. And by going deeper, you start creating a much deeper lesion, and the lesion shape also starts changing. So initially it is like more like a disc shaped, like when you use a non-irrigated catheter, but with an irrigated catheter, you deliver more wattage into the deeper tissues, and that leads to more like a teardrop kind of shape. So so this is how you protect the surface while you are heating the deeper tissue. So deeper tissue is heated more effectively with a irrigated RF catheter. So like when you take a normal catheter and you see the depth to which you can create a lesion, it becomes much higher with an irrigated ablation catheter compared to a non-irrigated ablation catheter. So this is actually a question for like the audience actually. So effect of cooling on the radial temperature gradient. So actually this is not a question, like I actually gave the answer right here. So A is actually 4 millimeter non-irrigated catheter. So you heat the catheter at 20, and the tissue temperature at the interface is 70, and it quickly goes down. 4 millimeter irrigated catheter. So B, you can see that the tissue temperature at the interface is high, and then it goes much higher in the deeper tissue and then comes down. 4 millimeter irrigated catheter at 20 watts. You can see that at the interface it's 40, but at the deeper tissue it goes beyond 50. You want 50, right? 50 is the threshold at which ablation happens. So you are actually creating deeper lesions with the irrigated catheter. Is this part clear? Any questions about this issue actually?
Another variable would be the flow rate in the irrigation. Do you want to talk about that a bit?
So the flow rate, we have more efficient cooling systems. Ultimately, what we need is effective cooling at the interface. So initially, when we started with irrigated ablation catheters, the standard flow rate was around 30 and 35 cc's, 15 and 35 cc's for irrigated ablation catheters. Now we have SF catheters. It's very popularly used in US. Not entirely sure if it's available in India, but SF catheters, it's a surround flow. The concept is that it can cool the tissue interface, like the catheter tip interface, with much lower amount of flow, and they say that like you can do a great job with just a limited amount of flow, and that keeps the temperature cool. But typically, if all things put together, all things being the same in the same catheter, the more you create a flow, the more.
मैं खड़ा हूँ इमरजेंसी के सामने गाड़ी में हूँ.
So higher the flow, the higher the irrigation, lower the interface temperature.
And Dr. Arun, are you going to talk about saline and half normal saline, or?
Yeah. I think I have a slide later on.
Okay, sure.
Yeah. So half normal saline becomes important for deeper lesions because the ion content in a half normal saline is much lower, and that leads to less dissipation of energy into the surrounding, the environment. So you're creating an environment where you're irrigating, and the irrigation has a lot of ions in it. Then it will lead to more conduction through the environment, and like less amount of energy will actually go into the tissue with a normal saline. But with a half normal saline, since the ionic content of the irrigation material is low, the environment actually has lesser conductive tissue, and most of the energy is actually preferentially going into the myocardium because that's a better conductor. So if energy is doing the job, how much energy is needed to produce the lesion? I have a question here on the chat. So if energy is doing the job, how much energy is needed to produce the lesion? We say 50-degree temperature produces damage. How much is that in energy terms? Actually, we don't know the answer to that. It depends a lot on what the tissue is. Like the amount of energy we are actually measuring is the energy that is going out of the RF generator and coming back to the RF generator. That's what we are measuring in terms of wattage and voltage and all that stuff, impedance and everything. We do not know how much energy is being dissipated into the actual tissue right next to the catheter tip. We know that like that amount of energy is being dissipated altogether, starting from the catheter to the grounding patch. How 8 millimeter has higher risk of charring compared to 4 millimeter when there is natural cooling possible in the former. 8 millimeter has lesser risk of charring compared to a 4 millimeter unless it is dug into tissue actually. So like 8 millimeter, if it is used properly, it has lesser risk of charring. Can I keep going or any other questions?
Yeah,
Yes,
I think
please,
we
go
can
ahead.
go ahead. Yeah.
Okay. So irrigated cooling. So advantages: reduces the coagulum risk and reduce boiling of the blood. Higher power can be used, and it leads to a greater depth of lesion. Disadvantages. So the biggest disadvantage is that surface cooling makes the lesion monitoring very difficult, almost impossible. You can't tell how much is the tissue temperature because you are actively cooling. So you are undoing your own job, right? Like you are trying to heat the tissue, but you're cooling the surface. So there is no way to measure the temperature. So deeper steam pop risk. So with a non-irrigated catheter, the steam pops, even if they happen mostly at the interface because that is the highest temperature. But with with an irrigated catheter, the risk of a steam pop is much deeper in the tissue. One more disadvantage is lower power and higher blood flow. It leads to dissipation of leak. Like with very low power, like you can't like it leads to a lot of dissipation of the heat because you are irrigating the catheter. Why closed loop irrigation?
Arun, 1 second. Let me go back to the last line you said, and apologies for the interruption. So if you are someone who doesn't understand contact, and I like to keep coming back to contact most of the times, if contact assessment is a challenge, it's better to use a non-irrigated catheter than an irrigated catheter, assuming that you are using more or less the same amount of energy delivered to tissue.
So very interesting question. So you are asking if we can use the catheter temperature as a surrogate for contact, right?
Yes, that would be possible with a non-irrigated catheter as compared to an irrigated catheter. In the irrigated catheter, you would not be able to use the catheter temperature measured as a surrogate for contact. But in a non-irrigated catheter, if you are able to reach a particular temperature that you want for ablation, it would mean essentially that you are in good contact.
Right. So you're absolutely right. So you can use the tissue temperature, you can use the catheter tip temperature as a surrogate for contact because otherwise you are not heating anything. You won't know if you're giving too much contact though, because
yes, of course.
Then there is no way to tell.
Yeah.
There is another thing that you can try, like you can use, that is impedance. If the impedance is too high, then you know that you're in blood pool. So if you're touching the myocardium, your impedance should be in range. So the usual range, like in pediatric cases, is obviously lower, but like in adults, it would be like 100 to 130. So if you're in that range, you know that you are actually touching the tissue. If your impedance is too high, then you are actually in the blood pool.
Okay, thanks, man.
Okay. So one question just for historical interest, like why did closed loop irrigation catheter go out of favor? In a closed loop irrigation catheter, the coolant did not exit the catheter, right? So like it was the cooling effect was limited to the catheter tip. It was not actually effective in cooling the tissue interface tip actually. So like it was not effective in like cooling the endocardial surface. It was cooling the catheter tip, but still you would have like coagulum formations and char formations. So it went off favor, and people started using more open loop irrigated catheters. So when irrigated catheters became more famous, like more popular, so we had to develop another mode of controlling the RF ablation. So you can't rely on temperature anymore. So there is no value for temperature control mode. So then you start using power control mode. So you are setting a maximum temperature, like you still have a maximum temperature at which RF energy cuts off, but what you're controlling is the power. So you're in an irrigated ablation catheter, you set the power at 30 or 40 or 50 or whatever, and the RF generator will constantly give that particular power unless there is a event where the temperature becomes very high, and then it cuts it off. So tissue electrode interface temperature is not a reliable indication for lesion delivery. So then you start using other things like impedance monitoring. So we'll talk about lesion monitoring, but like impedance monitoring is one of the ways you can tell whether you're delivering a good lesion or not. So we'll go to a question again. In an irrigated RF ablation catheter with power control mode at 35 watts, the RF repeatedly stops because of reaching max temperature set at 50. What could be the potential reasons? Irrigation is not working. Catheter is stuck in a recess or a pocket. Risk of coagulum or perforation if not recognized. It's an irrigated catheter. Ideally, you should be able to cool the surface, but RF generator keeps telling you that the temperature is maxing out and it keeps coming off.
We have about 24 to 26% participation. Going to encourage everybody to just take a stab at it. I mean, it's a 50% chance you're going to be right any which way. And this is a common challenge. Okay, so sharing the results, those are
Okay.
gambling.
Actually, like, guys are right. So I made a mistake with this question. Like I should have had a third option, which should say both. So this became a trick question. Like I didn't intend it to be a trick question. So when you have temperature which keeps going up, these are the two most common things. Like you should immediately check if your irrigation port is on or not, and you should also check if your catheter is stuck in a recess or a pocket, because if you don't recognize that, you can end up perforating it. So when you are stuck in a recess, what happens is that you're not irrigating it properly because your catheter is so tightly in contact with the tissue that like you are not able to deliver any kind of irrigation onto the surface because the irrigation ports are blocked, and that can lead to temperature going up. So if you remove this happens very commonly in pouches, like in pouches inside the CTI, or when you're ablating at the base of the papillary muscle or something, like your catheter can get stuck, and you're not irrigating properly in that location, and then like your temperature keeps cutting off.
I'll just add one point here. Suppose in the same situations you were using a non-irrigated catheter, your temperature actually will go very high very quickly because there's no blood flow there and there's nothing to cool the catheter tip. And so that's why in these situations, non-irrigated catheters do not work, and it's recommended. For example, in CS neck of CS diverticulum, or in a vein, CS vein, where when we ablate, or in as you said, in the papillary muscle region, when your catheter is between the papillary muscle and where the flow is very low, the temperature will rise very quickly, and so you will not be able to deliver enough power at all. And that's why it's recommended to use an irrigated tip catheter in such situations.
Right. Okay, so factors determining ablation efficacy and lesion formation. So Deepak has mentioned this multiple times. Contact force and catheter stability are the most important things, other than like the things that we talked about. Power and duration are the power and duration, we talked about it, and contact force and catheter stability are very important. Um, how much contact force is needed? You need good contact. You don't necessarily need a lot of contact. You need good contact to make sure that the catheter is actually delivering the energy inside the tissue. Because if you have lower amount of contact, like if you have like very little contact, it will not be stuck to the catheter. It will not be stuck to the tissue, and you'll have what is called as a sliding contact. With every motion of the breath or the heart, like you constantly have a sliding contact of the catheter, and that leads to passive cooling, because as soon as you have sliding contact, that leads to passive cooling from the blood pool. Intimate contact without cooling leads to a smaller lesion. So you can't have too much contact either, because if it's dug into a tissue, then it will lead to loss of cooling effect, like loss of irrigation, and that leads to smaller lesion. So risk of too much contact is perforation risk and collateral damage. So how do we actually measure contact force? Like this was the contact force catheters were developed in 2008. So you basically have 3 optical fibers which measure the micro deformation at the catheter tip, and based on that, it will tell you like how much contact force you have at the tip interface. So when you look at the contact force, like with the lower contact force, with the same wattage, your lesion delivered is very, very small, and as with the higher and higher contact force, the lesion delivered is much bigger, and with extremely high contact forces, you can risk a steam pop. Higher contact force can lead to steam pop. Contact force required to perforate is higher in our unablated. So like this is a question that I wanted to ask the audience actually. So does it actually what is too much contact force, right? So we need to know that what too much contact force is, and is tissue that is healthy like more vulnerable, or is it recently ablated tissue that is more vulnerable for perforation? Do you have any responses, Deepak?
Yeah, I do. In fact, we have a very interesting response. I shall just get it down there. There we go.
So you have a choice 3. So yeah, you're right. Like people are right. So 61% say recently ablated tissue, and that is right actually. Um, so this was a study that was done by Dipen Shah, and they tested contact forces required to mechanically perforate a wall in different chambers, and they showed that the force needed to perforate was lower in the right-sided chambers, like common sense, but they proved that. So right atrium and right ventricle are much more vulnerable for perforation with too much contact force compared to left atrium and left ventricle. And contact force required to perforate was lower for recently ablated tissue compared to healthy tissue. So healthy tissue is much more robust, and recently ablated tissue it can be very dangerous. So if you just ablated the tissue and you're going back to that area to ablate more, you got to make sure that you're not inflicting too much contact force in that location. So ideal contact force for ablation is around usually around 10 to 20 grams, but so 10 to 20 grams. Like anything beyond 170 grams is when you start. 160 to 170 grams is when you start having risk of perforation. So there is a good amount of leeway, but like you need to keep your contact force less than 20 ideally, because that's all you need to deliver a good ablation lesion.
Adding a comment here that since there are so many factors involved, power, duration, contact force. So whether you are making a good lesion or not, there have been many indices that have been developed, algorithms by different manufacturers, different companies. For example, there's an ablation index which takes into consideration the power, duration, and the contact force. And
Right.
another company has actually added impedance also to these three factors, and that is probably called as lesion index. So
That's
so
right. Yeah.
yeah, so just to incorporate different factors and combine into one parameter that you can actually look into while you're doing ablation. So otherwise it's almost impossible to know whether because of multitude of factors whether your lesion is actually being made or not.
Right. I think I have a slide on that actually, but let's do this question and then I'll go to that one. Which of the following has highest conductivity? Healthy myocardium, fat, fibrosis, scar, edematous tissue. I think the answer should be easy in this one, right?
Yep, just give me about a minute or so. We started the question a little bit later. Here you go.
Okay, good. So we have choice 1, 75%. They're able to see the poll results, or only I am able to see the poll results?
Everyone is.
Everyone is okay. So answer is 75%, like a healthy myocardium. So everything else has very high impedance values. So this is also important. So tissue characteristics that impact ablation. So healthy myocardium has high conductivity. It leads to a good lesion. When you have fat or fibrosis or scar, that leads to low conductivity and leads to poor lesion depth, and energy can get blocked or diverted. Okay. So and the same thing happens with edematous tissue. You would think that when you have edema, there is more water in that area and it can lead to better conduction, but that is not usually the case. Like acute edema can lead to very high impedance and like a very high resistivity, and lesion formation becomes very difficult when you have too much edema. So presence of fat is a big factor in epicardial VT ablations. You can't get good lesion because of fat. And the other thing is tissue orientation and architecture can also affect this. If you have trabecular regions or complex anatomy such as crista and valve annulus, that can lead to like more challenging ablation because the conduction is not linear. The other issue that affects the ablation lesion formation is coronary flow actually. So heat sink phenomena. when you have a coronary and you're heating around the coronary, because the coronary has a very a coronary vessel has a lot of blood flow, and there is a lot of heat dissipation in the coronary blood vessel, you can lead to protection of the myocardium around that area. So this is actually a rabbit heart preparation, and what they show is like they have this marginal artery and they are perfusing the marginal artery with saline, and they are putting the ablation catheters on either side and they ablate. And like at the location of the marginal artery, the lesion depth is always very small, and there is protected myocardium. The reason for that is because the coronary acts as a heat sink, and it takes up all the heat and like disperses it in the blood pool, and that leads to protection of the tissue around that area. Okay, so next we'll talk about impedance during ablation. So impedance, like we talked about, impedance can be affected by a lot of different things. So let's start with this question. During ablation on the base papillary muscle, impedance goes up suddenly by 50 points. Which of these following could this represent?
Deepak, next time we should have Jeopardy music going on while we are waiting for the poll.
Your wish is my command. Done. Okay, I'm ending this. Here, very interesting. Here you go. Can you see the sharing?
Yeah. You have some choice fives. Yeah, answer is all of the above, actually, any of the above. So steam pop can also lead to sudden increased in impedance. Catheter dislodgement can lead to a sudden increase in impedance, and coagulum formation can also lead to an increase in impedance. So impedance depends on a lot of different factors. Like it depends on the BMI of the patient, how big the patient is, lungs, how much volume is there inside the lungs, myocardial thickness. Scar can lead to lower impedance. Tissue temperature, like warmer tissue, leads to lower impedance. So there are a lot of things that affect impedance. So it's very difficult to figure out which part of this entire like a conglomerate is affecting your impedance at a particular situation. So but like when you have the way we monitor impedance and like see how the impedance is behaving is you try to figure out what the baseline impedance is. So once you enter the heart of a particular patient, you have to see what your blood pool impedance and what your tissue impedance is. Like if your impedance is around 110 to 130 and all of a sudden you're noticing an impedance which has gone down to like 90, or if it's gone up to like 160, then you know that something abnormal has happened, right? So then you need to readjust. You are either inside a like a deep pocket or something like that. So like you have to use the patient as their own baseline to understand what's happening with the impedance to negate everything else. Okay, so some of the ways to manipulate impedance would be to use a second grounding patch or get the grounding patch closer to the chest if possible. The ultimate way to manipulate impedance would be bipolar ablation. So that is one way to actually control the impedance and like also get a very deep lesion. How do we ablate? What is the concept of bipolar RF delivery? So it's probably most beneficial for VT. What we do is you have a ablating catheter and then you have a return catheter, and the return catheter is connected to the generator. So instead of having a grounding patch, the return electrode is actually right next to your chamber in the heart. So if you have a septal VT, you can put a catheter on either side and then you can create a transmural lesion. So basically the current is going between the two catheters, so there is very little collateral damage risk, and it also it creates a transmural lesion. The problem of course would be like you can create very high temperatures between the two catheters, and that can lead to an increased risk of steam pop. So any questions about that? So we can keep moving.
One comment that what impedance we are talking about is the system impedance that your ablation monitor shows. But there are a lot of other impedances in multiple places. And one which is very important and has recently been seen to be a very good marker of lesion uh, depth and lesion size is your tissue impedance. Now, look, or we call this as local impedance, where the actually the lesion happens. And though they are not good ways of mapping this local impedance, but that will be the proper way to look at whether your lesion depth is adequate or not. So, comments about that, Arun? There's some
Yeah.
systems which
Are you aware of systems which measure local impedance?
we don't have it in India, so I'm not very clear about those. But
Yeah.
I
Yeah,
think
I
in
think like
US they use it.
measuring local impedance is very difficult. So that's the reason we watch for the live impedance during an ablation lesion. So because let's assume we start with an impedance of about 120 and you start an ablation lesion, and then if the impedance drops down to 110 or like 105, like you have a 15 ohm impedance drop, nothing else has changed in the system except for the lesion, right? So like the patient's body weight is the same, everything else remaining the same. If there is an impedance drop, then we kind of assume that that is because of local impedance drop, because like everything else in the system remains the same. So then we say that it is a adequate lesion. So that is one way of lesion monitoring. Now the issue is like you can have some variations in the case too, like if you, I don't have a graph like that, but there are some graphs you can see like in publications where you can, the impedance actually varies with every respiration, and it is very pronounced in some people compared to other people, because as soon as the lung fills up with air, the impedance in the system goes up. So there is actually a respiratory variation, like a wave like variation with the respirations. So you can have a system where you are negating the respiratory variation and still be able to account for a lesion like an impedance drop at the local level. So bottom line is you need to see what is happening live in the patient, and you might be able to assess what the impedance drop is at a local level if you assume that everything else in the system is remaining the same. But I'm not aware of any systems where they are measuring interface impedance actually. Um, so we have one more. I think like we talked about it already. I think I'm gonna skip this just for the sake of time. I wanted to just talk about high
Arun,
power
go
short
ahead.
duration.
Arun, go ahead with the question if you think that's important. Don't worry about the time.
Okay, sounds good. So this is about high power short duration. So delivery of 50 watts for 10 joules, that would be a total of 400 joules, and 20 watts for 20 joules. Again, like 25 watts for 20 joules. Sorry, both of them are 500 and 500 joules. Sorry for the multiplication error. So 500 joules in each situation. One of them you're delivering at 50 watts and one of them you're delivering at 25 watts. Which of these leads to a deeper lesion?
Okay, I'm going to terminate the poll. Here are the results.
Okay. So choice one, everyone saying that like a delivery of 50 watts would give you a deeper lesion. Yeah, so this is the concept of high power short duration, right? So like a high power short duration ablation. So it's become a very popular thing for posterior wall of the left atrium. So the concept is that if you give a very high wattage for very little time, that leads to more resistive heating and less conductive heating, and the lesion remains superficial. You can think about it in a couple of different ways. First one is, if you're delivering a wattage of 50 watts for 10 seconds, the amount of irrigation you're delivering is only for 10 seconds. And so that leads to a superficial lesion. It acts more like a non-irrigated catheter in that scenario. And if you're delivering a 25 watt lesion for 20 seconds, you're also irrigating for 20 seconds. So that leads to a more deeper tissue heating. So high power short duration is nothing but like a glorified resistive heating system, which is nothing but our non-irrigated catheters. So you have a new catheter with Biosense Webster, which is like a 90 watt catheter, and in that, like, you are delivering a 90 watt just for 4 seconds actually, and that leads to very superficial lesions. So we use it in posterior wall for atrial fibrillation ablation. The theory is that, like, it can deliver shallow lesions and protect the esophagus. Esophagus doesn't get heated up. I don't do high power short duration lesions. There are some issues with it. Like, if you end up delivering high power for higher duration by mistake, then you're screwed. Basically, you're like you can end up causing like deep lesions as well as like superficial lesions. The other issue is, if you really wanted to just deliver a resistive lesion, you can always use a non-irrigated catheter. You don't need a irrigated catheter for this purpose. That's my bias. There are a lot of people who have started using high power short duration now.
Dr. Arun, actually the schematic, although we say shallower lesions, the lesion is larger and actually it is deeper than the image on the left, isn't it?
Oh yeah, that's right. So, but the surface width is higher actually. Yeah. What is 90 into 4 would be 360, and here it is 500 actually. This is actually the overall. I don't know if he's talking about the overall or like a lesion depth, because part of it is like non-effective ablation, because I think it's only reaching like 30 to 40 degrees Celsius. The biggest lesion is only around this area.
Right.
So other issues you have, if you have a metallic device near an ablation catheter, this happens very commonly in our patient population, right? Because they have pacemakers and ICD lesions, ICDs tips and all. RF ablation catheter, if it is in close proximity to a metallic device, it can lead to heating of the exposed metal, and it can also happen when you're using like two catheters very next to each other, like lasso guided ablation that we do sometimes in pulmonary vein isolation. You can have metallic device heating, the metallic device can act like a heat attractant, and it can be a conductor, and that can lead to heating of the exposed metal. So sometimes when we are ablating near the pacemaker lead tips, that can lead to scarring of the myocardium right near the lead tip, and that can lead to increased threshold of the pacemaker. So you have to be aware of that. And in AFib ablations, we use a temperature probe in the esophagus, and there is also a concern that like you can start heating up the probe because of the presence of metal directly, and that can lead to esophageal injury. So that is another risk. Okay, so we talked about this one before. So like, it's a repeat question. Let's see if people get it right now. You are ablating near the left atrial appendage ridge, 40 watt irrigated catheter. You notice a gradual drop in impedance to 12 ohms. What does this indicate? Concern for steam pop, concern that irrigation is not working well. You're all right, you have a good lesion.
So this is the result. What do you think?
Good. That's great. So we have a gradual drop is good. So anything, any gradual drop between 10 to 20 to 12, 20 ohms is considered to be a sign of a good lesion. So you can have so this like there is actually a concept that when you have an impending steam pop, so steam pop leads to a big lesion, big impedance jump. But just before the impedance jump happens, you can have a rapid decline in impedance because of increased tissue heating. So heated tissue can lead to lower impedance. So that can happen. There can be a sudden dip in the impedance before the impedance shoots up in a steam pop. But that is usually a sudden dip, not a gradual dip. If you have a gradual dip in impedance, that is usually a sign of good lesion. Okay, we actually talked about this one. Any of the above is the right one. Okay, so monitoring lesion formation. Any questions up to this point? We'll talk about lesion monitoring.
We have a couple of questions in the chat box. Sorry, go ahead.
Okay. I see a graph actually.
Ajay sir, Karthik sir, the one that Saktivel has asked.
Yeah, so Saktivel says that my understanding is impedance in an electrical circuit can be measured only when the current is passed, like pacing or shock impedance. How come the impedance measured even before the delivery of RF energy?
Very good question. So I think the simplest answer is that like when you have a catheter and it is not ablating, it is still sending out electrical signals to measure all these parameters. Because the catheter is not completely inactive when a catheter is sitting still and we are not delivering ablation. So the ablation catheter is always active. It's delivering like small pulses of energy to like measure the location as well as the it's also like measuring impedance.
So
That's
just to
absolutely
simplify
right.
that, yeah,
There's
just
a
to
small.
simplify that,
Go ahead.
yeah, yeah. So I'm saying that impedance basically means that there is resistance to flow. So when your catheter is outside the body, you will see that the ablation, your monitor will also still show the impedance, but will show more than 1,000, more than 999, because the circuit is not complete. As soon as you complete your circuit, if you are in the contact with the tissue, myocardial tissue, you will have an impedance which looks in the range. If you are in the blood pool, your impedance will be very low. If you are in a area where your contact is too high, like in a branch of a CS, then your impedance will be very high. And so even without giving any delivery of an RF energy, you will get to see the impedance, because that tells you what is the resistance in the circuit. And this impedance actually is not measured at one level, it is the system impedance of the entire circuit. So it will have impedance at the catheter tip tissue interface. It will have the impedance at the your patch, the grounding patch, and the skin interface, and all the other places where there is an interface, and blood pool versus the catheter tip interface, all those things. So all those things are combined together in what this is called as the system impedance of the catheter ablation system.
Yeah, actually, I was making the same point. There is a small current always on the moment the catheter or system is connected. And Dr. Raja Selvaraj had talked about it during his first presentation also.
And
Yeah.
when we were talking about local impedance, it is again the local impedance in the tissue where you are actually making the ablation lesion. And there have been some catheters which we have not, which are not available in India, which can have some micro electrodes which can actually monitor the local impedance, and that gives you, that's a very good surrogate of the lesion depth and lesion formation. But unfortunately, we don't have that in India. But probably in US or Europe, they use those catheters. Probably developed by Boston Scientific.
Oh, the MiFi catheter. Yes, I think they have some MiFi catheter like a small electrodes at the tip, micro
Yes.
electrode, which are designed just to measure the impedance between the. So they have 2 or 3 electrodes right at the tip, and then they measure the impedance right between the tips actually. So that's how they measure the local impedance, right? So I have never used that catheter. It's not like super popular here, but it exists. Yes, it doesn't have contact force, so that's why don't nobody likes it. So
Yeah, Dr. Arun, a couple of questions. Actually, there is one graph chart by Dr. Gaurav Panchal. Unfortunately, the font is such that I cannot read it. I think we'll have to do it offline somewhere, some point of time, discuss that. The
I
question
don't know.
I have is
Yeah.
two practical issues. One is, where has this 43 degrees centigrade, 17 ml per hour irrigation figures come from, and how do you change it for a given case if you want to? And second thing is, a lot of operators here operate at different institutes, carry the system with them. They may not have access to irrigation pump if they want to use for a given case. And what we used to do in the past was use long sheath, use non-irrigated catheter, and infuse through the long sheath. And that used to work in some ways like irrigation. Keep the tip just beyond the sheath. We've done that. So your
That's
thoughts about both of these?
that is incredible. I mean, all this ingenuity is only possible in India. So like I don't think we have done that here. But so the first question, I wanted to make sure I'm understanding the question right. I think it is pretty programmable, right? Like how much flow you are delivering through the ablation catheter. You can program that. So there is a company standard recommendation for each catheter. They tell you how much flow to use for less than 30 watts and greater than 30 watts or something like that. For SF catheters, usually it is a very low flow, and for like around 15 or less than 15 cc's for less than 30, and like more than 30, you can go to 20, I think, like some 20 cc per second or something like that. For regular catheters, contact force catheters, they're using about 30 and 40, 30 and 35 cc's irrigation. You can do that, but you can program that. Even like for when I'm doing an ablation in CS, I ask them to give me the maximum irrigation possible through the system, even if I'm delivering very small wattage. Even if I'm doing a 15 watt or 20 watt lesion, I ask them to give maximum wattage, and you can do that. You can also do something called pre-irrigation. Like if you really the impedance is very high, and every time you come on ablation, you feel like you're hitting impedance targets. Then you can actually do pre-irrigation where you fill it up with saline before you actually burn. So I have done that. Like I usually use like a 5 second pre-irrigation before my burn comes on, and then I burn it with a maximum irrigation on the catheter. I saw a hand raised actually. I don't see that anymore. Is there any question?
Gaurav had raising his hand. Gaurav, you want to put in some thoughts?
Yes, I have tried using that, and I think it is by default in system. We can adjust irrigation rate accordingly in certain situation only, but it is according to the manufacturer. And I think the representative who is attending the case are quite familiar. So I have used that, and it is working very well.
Okay.
Okay, so monitoring lesion formation. So we talked about it, right? Like, so this is important. So how can you actually tell if you're delivering a good lesion or not? So tissue electrode interface temperature is a crapshoot once it comes to irrigated catheters. It's only possible in non-irrigated catheters. So when it comes to irrigated catheters, you need to have other ways to monitor your lesion adequacy. So impedance monitoring is one. You are looking for a 10 to 20 ohms drop in impedance with a lesion, and that would be considered as a good lesion. Sometimes there is something called electrogram amplitude titrated RF delivery. So we used to do that for pulmonary vein isolation. So this was the standard technique we used when I was in fellowship, but I've gone away from that. So we would actually put a lasso catheter just to measure the electrodes and electrogram signals and ablate and see if the electrograms are falling or not. So you actually titrate the RF based on whether you're like influencing the electrograms or not. So you can do that. Then direct arrhythmia suppression is useful in some cases. If you have PVCs and you're ablating VT, you can directly ablate when the VT is happening, and then you know if you're giving a good lesion or not. And ultrasound imaging is getting pretty popular now. So like we use ICE for a lot of our cases. Majority of our cases we are using intracardiac echo, and so this is one of my cases where we are doing a papillary muscle lesion, and my catheter tip is on the catheter is on the tip of the papillary muscle, and you can see that there is a white lesion. So you can see that lesion forming in real time when you are ablating. So that is also an indication that there is good lesion delivery. Lesion indices. So the companies have come up with some lesion indices, like to tell you whether to give you a assurance that you are giving a good lesion. I'm not entirely bought into the fact that these formulas can tell you whether a lesion is good or not, but this is the best we have, and a lot of people use it religiously in this country. So basically all the lesion indices take three things into account: power, time, and contact force. So LSI, this is an Abbott system. It's a function of power, contact force, and also a duration of the lesion. An ablation index is also a power, time, and contact force. This thing, I'm not actually sure if any of these take impedance into account, but I guess that could be a good surrogate too. Like Dr. Bhargav was mentioning, maybe there is an index where they are using impedance too, apart from the power and contact force. RF ablation summary points: tissue injury reproducibly occurs at temperature of about 50. Non-irrigated catheters, interface temperature is higher than deep tissue temperature. RF lesion is proportional to the electrode radius, tip temperature, and delivered power. Larger tip electrodes allow for more delivered power, and temperature control mode makes the most sense in non-irrigated catheters. In irrigated catheters, it allows for greater delivered power by cooling the surface. Interface temperature is lower than the deep tissue temperature. Power control mode is the best with upper temperature limit, and contact force increases the lesion size. Have one slide about cryoablation. So cryoablation is basically the opposite of what we are doing with heating. We are trying to cool the tissue, and how does it lead to a lesion? Basically, what we are trying to do is, like, we are using a refrigerant gas. It's like, and we rapidly let it expand at the catheter tip, and that cools the tip. So the tip becomes extremely cold, and that leads to waves of cryo lesion. Like the temperature is very, very low at the catheter tip interface, and then like it leads to like a bigger lesion inside. So any tissue which hits a temperature of less than 0 degrees, it will have like ice crystals and cell death. And 0 to 32 degrees, you can have some electrical function, that is transient loss. But if you reverse it quickly, and if you warm the tissue quickly enough, you can reverse it. So that's why it's a little bit more forgiving, and people use it in pediatric age groups when they are using it near the node, or when they're using it for pathways near the node. And one slide about pulse field ablation and compared to the DC that we talked about. So pulse field is a return of the DC current. So we like RF ablation is a use of AC current to create alternating current is used to create RF wave RF radio frequency waves which actually like heat up the ions. But in DC pulse field ablation, we use DC pulses. Instead of using a longer continuous DC pulse, they use like extremely ultra short pulses of electrical impulses, and these strong electrical fields across the cell membrane leads to pouring of the cell membranes, and that leads to irreversible tissue injury. The way it's helpful is because myocardial cells have a much lower threshold compared to any other tissue in the surrounding regions. And so that's why electroporation is so focused, and it's so like it's becoming so popular, because it protect, like the risk of collateral damage is extremely low. That's it. Any questions?
Ajay sir, Karthik sir. And it's okay to have questions. I know it's just 11:20. 10 minutes to.
There is
Yeah.
a question here on the chat actually. If the site of lesion is near coronaries, decreasing the flow rate helps in decreased injury to the coronaries. I guess
If
it's
I
just
may try to attempt to answer this, I feel that it's actually not correct. Now, when you actually increase the flow rate, what happens is that not only your catheter tip is getting cooler faster, or more cooler, your tissue temperature in contact with the catheter tip also becomes a little cooler because the heat is withdrawn from that interface. And so your surface lesion, size of the surface lesion becomes smaller. So in fact, in areas like posterior wall of LA, where we just want a very small, thin lesion, not a deep lesion, but a thin lesion at the site of the catheter tip interface, actually reducing the flow rate will be actually more beneficial. On the other hand, the lesion depth is probably not affected by the flow rate because lesion depth remains same because the conductive heating remains the same, but the area in contact with the catheter tip becomes actually, if the flow rate is more, becomes less hot, and so the lesion in that area is actually smaller when your flow rate is high. So it's actually quite complex to understand. And we also missed about the irrigant, whether to use normal saline, half normal saline, or hypertonic saline. How does that affect that? That's another very interesting concepts about that.
yeah. So I think I was talking about the half normal saline and normal saline. So ultimately, when you do use a there is one thing that I did not mention. So like when you use RF ablation, you're not creating electromagnetic waves. You're actually creating you're using the alternating current, and the alternating current is like oscillating with the frequency of radio frequency, basically like 500 kilohertz. So the way the tissue is heated up is by the current actually, this oscillation creates a very local electromagnetic field that leads to ionic vibration. Like all the ionic ions in the tissue will lead to like very high frequency vibration, and that leads to resistive heating. So the more the ion content in the surrounding tissue, the better the more the dissipation of current in that location. So when you look at the myocardium, so the myocardium is rich with electrolytes and all that stuff, right? So like it's very rich in ionic content, and that leads to a selective heating of the myocardium compared to scar tissue or fibrosis and things like that. When you start using the irrigation ablation, when you start using irrigation with normal saline, you're trying to do that for a good reason. You're trying to cool the tissue surface, but you're also creating an environment where you're constantly, like bombarding the environment with like ions, like with normal saline, right? So if you are able to, and like apart from the tissue environment that you're creating, you also have like blood which has a lot of ions. So if you're able to protect the local environment with something that is not ionic, like a hypotonic saline, so you are protecting the catheter from the surrounding blood, as well as you're trying to selectively send the energy into the myocardium. So that is the concept of half normal saline. So when you are irrigating with half normal saline, you are creating a local environment which has a dearth of ions, and thereby like you're creating a resistive zone, and like the current doesn't selectively pass through the local environment, and it actually goes into the myocardium. So so we use that in like VTs, right? Like when we are trying to give very deep lesions in the ventricular VTs, and if we like for usually I end up having to use that in pap muscles. I try with normal saline first. If it doesn't work, then we go for a higher wattage, like for 50 watts or something. If that doesn't work, then my next go is like half normal saline. We use the half normal saline, we switch the bag and change it to half normal saline, and try to give a lesion with the half normal saline. If that works, great, but you can't give the patient half normal saline for a long time. Then you then you start creating hyponatremia and all that stuff. So that is usually not my go-to for an entire case. I only use it if things are not working otherwise.
The rule
So
of
just
thumb, sorry, sir, go ahead.
just one comment. So just to put all these things in perspective, when we are delivering RF energy, now suppose your catheter is in the blood, it is not touching the myocardium at all. So the whole of the energy get dissipated into the blood. When you are touching the myocardium or the tissue, a part of this goes to the tissue, but again, the majority is dissipated in the blood itself. So, so the delivered energy of say 40 watts means that about 75% will go to the blood and 25%, for example, goes to the tissue. Now, when you give an irrigant like a normal saline, you are cooling the catheter tip, but again, because of the ions, your dissipation into the blood increases even more. So, although you are allowing more energy to be delivered, again, more of it is going into the blood, but still higher goes into the tissue. Now, if you change your irrigant from normal saline to half normal saline, again, although you are still cooling of at the same amount, if your flow rate is the same, but your dissipation into the blood is reduced, and so more energy goes into the tissue, allowing you to have a much larger lesion. So that's how one should maybe understand this, how half normal saline sometimes is beneficial compared to normal saline.
Yes.
The other corollary of that, if you end up using 3% saline, say in an end zone like a coronary artery, sorry, the distal GC-AIV junctions, say you want to go down and you're not able to get your catheter in there, sometimes it's useful to use 3% saline, hypertonic saline there, because then again it increases the superficial nature of where you want your lesion to go. Because of the hypertonicity of the saline, you have more ions, the lesion can actually go and spread more superficially within the confines of the ECS. So both sides, I mean, using either side of it, deeper lesions with lesser tonicity, more superficial, wider lesions with greater tonicity. And to your point, Dr. Karthik, that brings into focus the orientation of the catheter tip to the surface. If you end up having something that's perpendicular versus something that's side on touching the surface, the more side on you are, the better the lesion because of the tissue contact. The area in tissue contact would be increased, hence bigger the lesion, probably more safer, I would assume, because of the current density.
Agree.
Yeah,
Yes, very important point by Gaurav actually. Half normal saline does carry higher risk of steam pops. The reason for that is again like we are cooling very effectively and you're delivering power very effectively into deeper tissues. So the steam pop, the tamponade risk, I just want to make one mention. So when you steam pop and your pop is actually endocardial, your risk of having a tamponade is low. So like we have like we have steam pops very regularly when we are ablating in papillary muscle area or like thick left ventricular tissue. Usually that doesn't lead to anything, but it's still scary. We should stop the ablation immediately and we check the patient and all that stuff. But steam pops are very common when you are ablating in the thick tissue. The worry is low. The worry is when you have a thin tissue and your steam pop connects the epicardium, right? So like when it goes through and through, that's when the risk is. So sometimes the steam pops could actually work in your favor if you're burning extremely thick tissue like papillary muscle base.
yeah. Often it used to happen that resistant arrhythmia, you're ablating often in flutters. You're ablating for a long time. The flutter is not going, and you have a steam pop, and the flutter terminates, and you've got a isthmus block also. That used to happen sometimes.
Yeah.
Same with VT
Yes.
ablation, especially over the scar. Yeah,
And in situations like this where you are very prone to having steam pops, use of ice actually helps you looking at the tissue edema and maybe tissue temperature rise and the effects it shows on the boiling of the cells, water in the cells on the ice. You can actually stop your ablation before the steam pop actually occurs. So ice may be very useful in such situations.
Yeah. I use ice in all my ventricular cases. it's pretty commonplace here, and it's not easy to tell a good lesion from steam buildup actually. So like oftentimes by the time I see a flurry of bubbles, the steam pop has happened, and I also don't see this beautiful curve of the impedance rising. So like sometimes the steam pop is so silent, all you can feel is like a pop in your hands, and then like you see a flurry of bubbles actually. Um, the other issue I wanted to actually bring up was the problem of edema. So when you are ablating in CTI for a long time and you can't get a CTI block, typically that's because you have developed a lot of edema. And once you have edema, then you are just fighting a losing battle. You're trying to ablate a lot, but it doesn't work. So then you have to actually go map on the lateral aspect a little bit more and try to find a passage where the tissue is coming from, and then burn in that location. So usually what I do is, like, if I'm 6 o'clock on my CTI and I'm burning quite a long time, and I don't get a block, then I go to the 7 o'clock area and like map for the earliest activation when I'm pacing from the CS. And usually there is an epicardial connection which is surpassing the edema and coming on to the other side, and you can burn there. You need to find a tissue that is more amenable to ablation. Otherwise, you are fighting a losing battle when you have a lot of edema, because you're just creating more edema by burning.
Very true. And in fact, it's even more problematic in accessory pathway ablations if you have done multiple ablations without very good mapping, because then I think the only option is to leave it for some other day, because you need to be very precise in your mapping and then only ablate. Once you have
Yeah.
created the edema, then it will never go during that sitting.
So,
Do you guys
Dr. Arun, I have a
like,
research idea for you. In the
yeah,
past, Bison's Webster used to create a catheter which had a needle in the front, which you could advance and inject.
right.
So now what you need to do is have some kind of a temperature monitor incorporated into that, so we can actually get tissue temperature in live humans when you're doing cases.
Yeah.
So the needle should be able to pick up the temperature below your surface.
Right. Yeah. That'll be cool actually. They've been talking about that needle catheter forever, right? Like it's not come out.
Oh, I've used it. I've used it in, of course, in some research. I've used it in this.
Oh wow. Okay. Does it work well?
Yeah, it's pretty good.
So
I believe it's for intramural
Yeah,
VTs or
intramural lesions and intramural injections. We actually injected methylene blue through it in porcine hearts, and then dissected the heart, and looked at what the methylene blue looked like. So it's a pretty cool thing. It's available in research.
you can inject alcohol and all.
Yeah, you
too?
can do that. Yeah.
Okay. So do you guys use cryo catheters, focal cryo catheters?
Yeah, only some centers in the country, but we do have that resort. Yeah.
Okay. So sometimes the one of the things that I do for my papillary muscle VTs is, if I'm burning for quite a lot of time and I'm not able to get suppression of PVCs or VT, and I like typically that's number one, it's because it's too deep, right? And we can't get it. And number two is like I've created a lot of edema and I'm fighting against myself. So then I switch my catheter to cryo catheter, because there is so much edema, the ice crystals can form more easily. So then like so I very frequently change to a cryo catheter, because at that point it's futile to just continue with RF, and then use a cryo catheter, and sometimes I've had some success with that. But papillary muscles, I have realized that the more you map, it's very helpful to have a good map at the beginning of the case. If you start burning without good mapping, then it's very difficult. So a lot of papillary muscle VTs are about 35 to 40% of them actually come from the tip, and about 30% come from the body, and 30% come from the base. So if it's a tip papillary muscle VT and you start ablating in the base, you will never get it. Like you have to map it very intricately, and then like identify that it is on the tip and then burn there.
great points and great learning.
Yeah. Deepak, have we overshot the time already?
No, we can go on for another hour, or maybe till the CSK MI match, we can continue. No
I
problem.
think Arun needs to sleep.
Yeah, yeah. So some final words, Arun, Dr. Bhargav, Ajay sir, and then we can wrap this up.
I think this was a fantastic session. Arun, thanks a lot. We covered a lot. Karthikeya?
Yeah, I agree completely. It was a great session with great discussion as well, and I believe it will be useful for everybody. Thank you,
Thank you
Arun.
very much for the opportunity to talk. Like I know you guys are a lot of you are very senior, and this is actually a really good session, very interactive. So a lot of questions.
Thank you. And hopefully next month we will come back with the same session. If not, we'll see you guys in May, where we already have a session planned on step by step for left bundle area pacing in patients with heart failure. So we look forward to that. Thank you once again for being here. See you soon. Have a great Sunday. And as usual, hopefully CSK wins. Bye.
Thank you.
Thank you all.
Bye.
Thank you.